Okay, so good afternoon, and thanks for inviting me to speak. My name is Apostolos, I'm a cardiologist, and I will be discussing what the interventionalist needs to know about echocardiography, mainly with a focus on the structural interventions. It's a quite broad topic, so I will try to make it more specific to structural interventions. So echo is no longer just a diagnostic tool. It's essential for planning, guiding, and detecting complications in structural interventions. It allows us to take real-time decisions and detect any complications promptly. When people are talking about interventional echo, they're mainly talking about valves, but interventional echo also supports a number of other procedures, such as congenital and electrophysiology-related procedures. Specifically, and for the sake of time, today I'm going to talk only about TAVI and mitral edge-to-edge repairs. And really, the watershed moment of interventional echo was the birth of TAVI more than 20 years ago, back in 2002. Ever since then, there has been a huge evolution in the available devices. The use of echo and cardiac CT help us to make the decision about who is the right candidate and what kind of TAVI valve to use. Nowadays, we also use, as I said, cardiac CT, so we can make those decisions based on cardiac CT data. However, echo is helpful in guiding some intra-procedural steps and looking for possible complications. So, for example, with echo, we can evaluate the depth of the TAVI stent. Normally, it should lie about 3 millimeters below the virtual aortic annulus. If you have a high implantation depth, then there is a risk of embolization, coronary artery obstruction. With a low implantation, then you may cause mitral valve impingement or conduction abnormalities. You can also look at the shape of the stent. Normally, you want to see a nice circular stent. If you see a deformed, oval-shaped or disc-shaped stent, that could imply that your stent is not fully expanded, which can lead to abnormal leaflet motion. You also need to look at for the presence of any transvalvular regurgitation, which can be a sign of leaflet abnormality. And you don't want to leave the patient leave the cath lab without dealing with that problem if this exists. Abnormal leaflet motion can be a sign of underexpansion. And the final part of valve assessment is looking for PVL. We use this clock face that you see in the parasternal short axis transthoracic view on the left, or sorry, not on the left. Using transthoracic or transesophageal echo, you can use a parasternal short axis views or mid-esophageal short axis views. And to determine how significant the PVL is, you really want to see what percentage of the circumference the jet occupies on the TAVI stent. Anything less than 10% is considered to be trivial to mild. Something between 10 to 30% is moderate, and more than 30% is severe PVL. But just keep in mind, though, that this is just one parameter, and eccentric jets are going through crushed calcium and leaflets, and they don't always have a straightforward course, so they may look like they cover a wide circumference, but they don't go out very, very far in the LVOT or the mid-left ventricle. And the main causes of PVL after TAVI are underexpansion of the stent, significant and/or eccentric calcium in the aortic valve cusp or the LVOT, suboptimal depth of the TAVI valve, or an undersized valve. Most of those can be detected with echocardiography. Now, the other landmark procedure that interventional echocardiography is very important for is mitral edge-to-edge repair. And this is based on the old Alfieri surgical repair, where a stitch is placed between the anterior, the A2 and the P2 scallops of the mitral valve. It was first approved in 2013 for primary MR. Now the indications and the patient candidacy has expanded significantly. And when I assess a patient for possible edge-to-edge repair, I look at the mitral regurgitation, look at the severity and what the etiology is, and then I examine the leaflet mobility, the leaflet calcification, measure the flail gap and the flail width, and look for any left atrial appendage thrombus. And then I assess the interatrial septum, looking for any abnormalities there, any PFOs, any other devices, prior AST or PFO closure devices that could increase the complexity of the procedure. And then you have the ideal mitral edge-to-edge repair candidates, and then less ideal on the right-hand side. So if you have a central focal jet, if you have good leaflet length, not thickened leaflets, not significant calcification, then that's probably favorable anatomy. Whereas a commissural jet, a jet that is very broad, a lot of calcium, especially in grasping areas, thickened leaflets, short leaflets, especially posterior, short posterior leaflet. All these can cause troubles. The key views to assess structural suitability for edge-to-edge repair is the mid-esophageal 60 degrees commissural view and the respective orthogonal views which are generated based on this commissural view. Using a 3D transducer, we sweep the cursor along the whole coaptation line with and without color to see where and what exactly the pathology is and where the MR is coming from. So you generate the images on the right-hand side. Morphological assessment should also include measurement of the coaptation depth and coaptation length, particularly for functional MR cases, and flail gap and flail width for DMR. Let's see some examples. This is a typical P2 flail. You have rupture of primary cord here, leading to flailty and a very eccentric anteriorly directed jet. This is a slightly more complicated anatomy where you see that's a mid-esophageal commissural view. You see something coming from the lateral side of the valve as well as the central part. So P1 and P2 probably jets. You move on to the orthogonal view and you see this eccentric anteriorly directed jet. And using the 3D, you can get all this information much quicker, so you see the typical P1 and P2 flail. This is an even more challenging anatomy, an A1 prolapse, a very lateral prolapse with a jet originating from the lateral side of the valve. And here with 3D, you can see a prolapse of A1 segment. Let's see some challenging or even cases that cannot be done with edge-to-edge repair. This is a cleft, as well as P2 prolapse. There's a deep indentation, or probably a cleft between P1 and P2, from looking at from the atrial side on the left side and from the ventricular side on the right side. This is endocarditis, so that's why you need to know the cause of the MR. You see the vegetation going in and out of the mitral of the LV. A very short posterior leaflet. There's nothing to grasp there. And then here you have multiscallop prolapse with a typical Barlow's valve. Here you have a lot of calcium in the posterior annulus, thickened mitral leaflets, flail P3, severe MR, mild MS, certainly not the easiest case to do. Once transfemoral access has been obtained, then the key to successful edge-to-edge repair is transeptal access. For mitral edge-to-edge repair, you want to be a little superior to maybe mid, definitely posterior and high in the fossa vallis. And so how do you figure out where you are? You look at the SVC and the IVC in the bicaval view. So close to the SVC is the superior aspect of the septum, and near the IVC is the inferior part of the septum, of the interatrial septum. And then at the mid-esophageal short axis, you look at the anterior, at the aortic valve, which is the anterior part of the septum, and the opposite wall is the posterior. There's a third dimension, and, so there is a third plane that's quite important in mitral intervention, and that's the height of the transeptal puncture of the mitral, the height of the transeptal puncture. So you look where your needle is tending the interatrial septum, you draw a line parallel to the mitral valve plane, and from there another line perpendicular to the first line towards the mitral valve plane. And you want this length to be more than 3.5 centimeters ideally. And then you use bicaval and mid-esophageal short axis views to advance your delivery catheter and your device. You want to place your device initially near the left upper pulmonary vein, and then you steer it towards the mitral valve, and you want to watch it on the mid-esophageal short axis view, clear the pulmonary veins, then clear the left atrial appendage, and then probably switch to 3D and get this view. Here you want to have your device oriented perpendicular to the mitral leaflets. You don't want to grasp A1 and P2. And you also want to check which gripper is anterior, which one is posterior, as you see here, this tiny thing that is moving, which is the posterior gripper. And just to remind you on the 3D mitral valve surgical view, this is extremely important as we plan device deployment. Anterior is, you see the anterior and the posterior part of the mitral valve. On the right side is the medial left lateral, and I don't want to go any further. Probably you all know that. It's quite basic. A1, A2, A3 on top of the picture, and posterior leaflet at the bottom. And then you probably switch to 2D, advance the device. You want to see the leaflets lying on the device arms. And then you lower the grippers. You want to see the grippers lifting with each beat, meaning that they are moving with the leaflets. So I move forward because I think we don't have enough time left. And then as you close the arms, you want to see the MR getting less. And from that point on, we now want to interrogate the device before we make a decision to release. We can do this with some of the newer techniques, such as live 3D M-TEER. You want to see a nice double orifice. You want to see a solid tissue bridge. You want to see minimal residual MR, if probably none. And you don't want to see excessive motion of the leaflets next to the bridge, because that would imply insufficient amount of tissue inserted. Success is if you have less than moderate MR and a mean gradient of less than 5. And this is a typical success, good outcome. And here you see probably a less good outcome. However, it's still probably acceptable. On the right side is a picture no one wants ever to see. That's a detached clip. Thank you.
Thank you very much, Dr. Vrettos. Indeed, nice information about the echo. Dr. Ravadinos, any comment?
Thank you very much, Dr. Vrettos, for the nice presentation. I would just like to highlight the importance of multiplanar reconstruction imaging during these TEER procedures. Just this, we use it many times in order many times to guide the intervention. I don't know what your comment about this.
Yeah, I mean, it's quite important if you have the technology available. You can see the fine details, especially if you find it difficult to orient your plane with. If you cannot orient your plane with a clip easily, then you can do M-TEER and look the very fine details. As I said, next to the clip, you can see if there is excessive leaflet motion. You may want to open again the grippers and the arms and try again, optimize, do some further optimization, and then get a good tissue bridge.
Thank you.
Any other comment? Okay, thank you, Dr. Vrettos.
Thank you.